Thank you very much, dear audience, for letting me present. I'm kind of crashing this kind of topic. I'm going to go back slightly to our beloved high-sensitivity cardiac troponin and acute coronary syndrome. My name is Anna. I'm one of the research fellows working with Professor Mills in Edinburgh, and I'm going to talk in the next 7 minutes about the performance in the real world of an early rule-out pathway for myocardial infarction. I'll keep it brief, I promise. So I don't have any conflicts of interest to declare. And just a little bit about the background. We all know very clearly, as the guidelines suggest, that we should be using early rule-out pathways for myocardial infarction with high-sensitivity cardiac troponin when assessing patients with acute coronary syndromes, with suspected acute coronary syndromes. It's challenging, and whilst this has been widely applied in clinical practice, these pathways have been derived from selective patient cohorts in research studies. And the question is whether the performance of the pathways and also the effectiveness of these pathways differs when applied to real-world, day-to-day clinical practice. So there was this large prospective patient cohort study done a few years back that looked to evaluate the influence of patient selection on high-sensitivity cardiac troponin testing and myocardial infarction across populations in the UK and the US. And the study authors showed that when troponin testing is performed widely, then elevated cardiac troponin concentrations are very, very common. However, the underlying cause for this is more likely to be myocardial injury rather than myocardial infarction. As such, they concluded that the selection of patients for high-sensitivity cardiac troponin testing influences the prevalence of myocardial infarction. The positive predictive value improved when things like symptoms and signs and underlying risk factors were considered. Furthermore, the authors also showed that there is variability across practices with troponin testing across the pond and across the world. So what we aimed to do was to evaluate how the selection of patients influences the performance, the diagnostic performance of the high-stakes early rule-out pathway when considering patients with suspected acute coronary syndrome. So we had 2 cohorts of patients. All these patients came to the emergency department across 3 acute care hospitals in Scotland. These patients had suspected acute coronary syndrome. All these patients underwent high-sensitivity cardiac troponin testing with the Abbott Architect high-sensitivity cardiac troponin I, and the diagnosis was adjudicated according to the 4th universal definition of myocardial infarction. We had 2 cohorts of patients, so I'll quickly explain about that. So we had an unselected cohort of patients. These were patients coming into hospital, all consecutive patients, as part of a service evaluation work. And we also had a more selected cohort of patients consented to take part in a research study that were enrolled during daytime hours by research staff. So our study populations, so the unselected patient cohort, those involved as part of clinical practice, comprised of 1,242 consecutive patients with suspected acute coronary syndrome, and the research study we had 1,695 patients consented to take part in research. Very briefly about some baseline characteristics. As you can see here, the median age was similar in the 2 cohorts. There were slightly more females in the consecutive patient cohort, in the unselected cohort. Chest pain was the primary presenting symptoms in both cohorts. And 1 in 7 patients had evidence of elevated cardiac troponin. However, interestingly, similar to previous data, the prevalence of myocardial infarction as a final diagnosis was lower in the unselected cohort. So, just going to the results and talking about the performance of the high-stakes pathway. I first want to concentrate on kind of the first step following the initial troponin testing. So we look at the low-risk category, those with a result of less than 5 nanograms per liter, the intermediate group, 5 to the 99 centile, and those in the high-risk group with ECG changes or troponin concentrations on admission of more than the 99 centile. So you can see here that in the unselected clinical care cohort, there were more patients in the low risk, whilst in the selected patient cohorts, there were more patients that went into the intermediate category and required serial testing. So the next step of the pathway is to look overall at the diagnostic performance, those ruled out and ruled in. And as you can see here, in the unselected patient cohort, more patients were ruled out, whilst with excellent negative predictive value, similar across both cohorts, whilst when we think about the rule-in of the pathway, in the unselected patient cohort, there were less patients ruled in with a lower positive predictive value. So very quickly here, we also classified the patients who were ruled in according to the underlying adjudicated diagnosis. And as I mentioned before, you can observe some differences here. So there were more patients with a type 1, 4B or 4C myocardial infarction in the selected patient cohort. However, when thinking about acute or chronic myocardial injury, there was a difference there as well. We had many more patients in the unselected patient cohort. So the performance of the early rule-out pathways for acute myocardial infarction are likely to differ when applied to clinical practice because the prevalence of myocardial infarction differs in these populations. In clinical practice, there are fewer patients ruled in with a lower positive predictive value for myocardial infarction. However, there are more patients safely ruled out admission without compromising safety. Thank you very much, and I just want to thank all my colleagues and mentors and supervisors, and welcome any questions.
Thank you, Ada, for this very nice practical study. Is there any evidence for cost effectiveness about this project?
So we haven't...
How many time saved in emergency department with this protocol?
So
if there is saving also costs?
Yes, so thank you very much for that question. So part of the high-stakes trial and also the follow-on historic trial, we have showed that the implementation of the high-stakes rollout pathway has significantly improved the flow of patients in the emergency department with kind of less length of hospital stay. So yes.
Question is, this troponin was from laboratory measurements or from point-of-care system?
So all these troponin testing was done laboratory.
Laboratory. Yeah. What about the point-of-care systems with high sensitive?
So it's again, a very great question. I think this is kind of the next area that we're working on to develop to improve the efficiency of implementation of these pathways. But I haven't tested in this work here now.
Thank you very much for this very interesting talk. But your first conclusion in the last slide, you said positive predictive value is low because the incidence is low. Is that correct? Positive predictive value is low because we include wrong patients in the pathways.
So again, a very, very good question. So I think there is kind of a number of reasons why this may be the case. Those patients that we include in research studies, perhaps they are more selected patients who want to participate and are kind of the worried patients about their health with maybe more risk factors for cardiovascular disease. Whilst we know from this data and previous data that in patients who, in the overall kind of day-to-day population, there is more patients that we would be testing that will have other reasons for an elevated cardiac troponin rather than myocardial infarction. So I think it's influenced by that as well.
Okay, so thank you very much again.